Hi everyone, today I'm going to present my systematic review about polycystic ovary syndrome or PCOS. My research question is, do low glycemic index or low glycemic load interventions improve insulin sensitivity and menstrual or ovulatory patterns in women with PCOS? PCOS affects 6 to 21% of reproductive age women, and nearly 80% experience an ovulatory infertility. In the US, the economic burden exceeds $4.3 billion yearly when long-term complications and pregnancy are included. Diagnosis is often delayed. Over one-third wait over 2 years, and almost half to see multiple providers before a diagnosis is made. Here are some of the signs and symptoms that women with PCOS experience. For example, irregular or prolonged periods, fluid-filled sacs or cysts. Basically, these are immature follicles, growth of extra hair loss, excessive cramping, bloating during menstruation, acne or other skin problems, psychological stress, depression, fatigue, pelvic pain, and also rapid weight gain. First, genetic and epigenetics play a major role. Many women with PCOS have increased activity of key steroidogenenic enzymes and disruptions in insulin and gonadotropin signaling. This alteration made the ovaries more sensitive to luteinizing hormone and more prone to overproduce androgens. One of the hallmark hormonal patterns in PCOS is elevated luteinizing hormone and follicle stimulating hormone ratio. When luteinizing hormone is higher, Teca cells overproduce androgen and the follicles don't mature normally. This is what contributes to irregular or absent ovulation. In addition to that, most women with PCOS have some degree of insulin resistance, often between 50 to 70%. As insulin resistance worsens, the pancreas tries to overcompensate by producing more insulin. As this hyperinsulinemia further stimulates the ovaries to even produce more androgens. Also, high insulin lowers SHBG, sex hormone binding globulin. It's a protein made by the liver, and the liver increases IGF, insulin growth factor, activity. Both of these changes increase the amount of androgens in circulation. There is also a molecular defect in insulin signaling. Pro-inflammatory cytokines like TNF alpha interfere with IRS insulin receptor insulin receptor substrate, which reduces PI3 kinase activity and decreases GLUT4 translocation. So instead of being able to take up glucose normally, patients remain insulin resistant and the cycle continues. Altogether, this pathway, genetic, hormonal, inflammatory, create a vicious cycle of insulin resistance, and androgen excess. What the image illustrates. Now, building on what we cover, it's important to recognize that many women with PCOS have genetic variants in insulin signaling pathways, as I mentioned before, like INSR and IRS1. These variants make insulin signaling less effective, so women are predisposed to insulin resistance throughout life. Because insulin resistance rises in proportion to blood glucose, the glycemic index becomes clinically relevant. The glycemic index simply tells us how uh, how, quick, how quickly a carbohydrate raises blood glucose after eating. Low glycemic index foods are absorbed more slowly, which leads to smaller insulin spikes and reduces the metabolic stress on the pancreas. In contrast, high glycemic index foods cause rapid um, glucose rises. This drives to large insulin spikes and can worsen hyperinsulinemia, androgen excess, and involuntary dysfunction. In the image, you can see some examples of low GI foods. The purpose of this systematic review is to examine whether low glycemic interventions improve insulin resistance and ovulatory outcomes in women with PCOS. Um, Methods. I conducted a comprehensive PubMed search covering the years 2010 through 2025 using terms related to PCOS and low glycemic dietary interventions. For the sample section, I included randomized controlled clinical trials, and pre-post interventions specifically involving women with PCOS that were diagnosed with PCOS. For data collection, I transferred all the results into an Excel sheet and then extracted study details such as sample size, intervention type, duration, metabolic outcomes, and reproductive outcomes. My inclusion criteria require studies to use low glycemic index or low glycemic load interventions and report outcomes related to insulin resistance, insulin sensitivity, or menstrual or ovulatory function. I excluded supplement-based interventions, pharmacologic or mixed diet drug studies, and studies that did not measure metabolic or reproductive outcomes. After applying the criteria and completing the full text review, 5 studies met the eligible criteria, and as summarized, as you can see in the Prisma flow diagram. Results. Across the 5 interventions, 4 of them measure insulin-related outcomes, and all 4 show significant improvements in insulin-resisting markers. These included reductions in fasting insulin, HOMA-IR or HOMA2-IS, and insulin AUC using the oral glucose tolerance test. What is especially important is the isocaloric or weight maintenance trials. Insulin sensitivity improved even without any weight loss. This shows that lowering glycemic impact and not reducing calories is what drives metabolic improvement. In the one hypocaloric trial, both groups lost weight and show improvements in SHBG, LDL cholesterol, testosterone, and HOMA-IR, but the low glycemic load group had even greater reduction in fasting insulin and HOMA-IR after adjusting the BMI. This suggests that there is an extra benefit of carbohydrate quality on top of calorie restriction. The pool-based diet produced the largest metabolic improvements overall, including greater reductions in 2-hour insulin response, triglycerides, LDL, and blood pressure. This suggests that not only glycemic index is important, but the composition of specific foods, for example, peas, lentils, or beans. For their reproductive outcomes, only 2 studies measure this, but both found meaningful improvements with the GI diets. In the trial by Sonia Hernandez, the low GI group had significantly more ovulatory cycles compared from 24.6 to 74.6 in the control group, with a p-value of 0.014. It's important to mention that for this trial, weight did not change in either group. this which indicates that a voluntary improvement happening without any weight loss. And it is like researchers mention that it is likely by the reduction of insulin resistance. In the other trial, women with on the low GI diet reported graded improvements in menstrual regularity, even though there were no significant changes in luteinizing hormone, FSH, testosterone, or SHBG, or the free androgen index. This suggests that menstrual improvements may occur before detectable hormonal changes or are driven primarily by improved metabolic signaling rather than direct endocrine changes. Together, these reproductive findings reinforce the pathophysiology of PCOS that if we improve insulin resistance, um, it might help restore more normal ovulatory patterns in women with PCOS. Overall, these findings support my original research question across the included studies. Low glycemic and low glycemic load diets improve insulin resistance, which aligns with the current MNT recommendations that emphasize carbohydrate quality as a key nutrition target for PCOS. In the two trials that measure reproductive outcomes, women on the low GI diets experience higher ovulation rates and better menstrual regularity. It's important to mention that these improvements happen without any change in body weight, and this reinforces the idea that improving insulin sensitivity, not weight loss alone, is what drives reproductive benefits. The isocaloric trials were important because they show metabolic improvements even when weight, calories, and weight circumference stay the same. This supports weight neutral strategies for women with lean PCOS who still struggle with insulin resistance. In the hypocaloric trial, weight loss improved both metabolic and hormonal markers, but the low glycemic load diet provided an additional reduction in fasting insulin and HOMA-IR after adjusting the BMI. This suggests that glycemic load may offer benefits beyond calorie restriction alone. The pulse-based intervention showed the broadest metabolic improvements, including larger reductions in insulin, AUC, triglycerides, LDH cholesterol, and blood pressure. This indicates that not only glycemic index, but also the nutrient composition of specific foods can play a meaningful role. Like taken together, these results suggest that improvements in insulin sensitivity are likely the mechanism behind the reproductive benefits observed with the low GI diets, and this supports the pathophysiological model of insulin androgen interaction in PCOS. However, several limitations should be acknowledged. Most of the studies had a small sample size, short durations, so making long-term effects uncertain. Dietary intake was self-reported, which always introduces measurement error. Only two studies measure reproductive outcomes, so conclusions about ovulation remain preliminary. Some interventions included exercise or counseling, so the isolated effect of glycemic index is hard to determine. Additionally, because diets varied across trials, difference in outcomes may reflect difference in food composition. Larger and more standardized studies are needed to determine the extent to which lowering dietary GI can improve both metabolic and reproductive outcomes in PCOS. In conclusion, um, based on the five intervention trials, lowering the glycemic impact of the diet improved insulin resistance in women with PCOS. What is especially important is that these benefits occur even without calorie reduction or weight loss, emphasizing that carbohydrate quality matters just as much than total energy intake. In the two studies that measure reproductive outcomes, low GI diets also supported better ovulation and improved menstrual regularity, likely through their effects on insulin sensitivity rather than direct changes in reproductive hormones. Taken together, the evidence supports that low GI and low glycemic load dietary patterns as a practical and effective component of medical nutrition therapy for managing both metabolic and reproductive outcomes aspects of PCOS. However, more long-term randomized trials are needed, especially in lean women with PCOS, with standardized reproductive measures to better understand the full impact of glycemic modification. Based on available evidence, low glycemic index, and low glycemic load eating patterns should be incorporated into individualized MNT for PCOS, focusing on high fiber, minimally processed carbohydrates, and weight neutral approaches when appropriate, along with behavioral support or physical activity to maximize the outcomes. Here you can see my reference list. Thank you everyone.